So firstly, let's turn to Professor Laurent Poirel of the University of Fribourg in Switzerland, who's going to talk on global resistance threats and trends in gram-negative bloodstream infections and really set the background to the problems we face. Over to you, Laurent, sir.
Thank you very much. So it's my pleasure to present today the global resistance rates and trends in gram-negative bloodstream infections. Which are the most concerning issues when dealing with bloodstream infections? We are used to consider two main issues. When you want to treat bloodstream infection, you need the right treatment, and we do consider that the earlier, the better. That means, using a microbiological language translation, that we need to have an accurate detection of antibiotic susceptibility and antibiotic resistance by preventing very major errors that actually correspond to the forced susceptibility results for the resistance microorganism. And this accurate detection is absolutely mandatory. And when we talk about fastness, we do consider that we need to use rapid diagnostics. This is critical in the choice of the relevant and accurate treatment. So which are the main bloodstream infection pathogens in humans? Gram-negative parts, you see here that the main ones are either Pseudomonas aeruginosa, Acinetobacter baumannii, and Enterobacterales like E. coli and Klebsiella pneumoniae. And these key bloodstream infection pathogens have been nicely summarized in that review. You may consider that E. coli is number one pathogen in most settings, most often related and involved in urinary tract infection, abdominal infection, but also neonatal infections. We do see some nosocomial outbreaks of E. coli in neonatal infections. And the problem of resistance is that there is an increasing resistant trend to fluoroquinolone and broad-spectrum cephalosporins. This is extremely common in BSI infections. So for Klebsiella pneumoniae, this is the second Enterobacterales species after E. coli being identified. And you have pneumonia, you have intra-abdominal infection, but bloodstream infection as well. And then you have Pseudomonas aeruginosa and Acinetobacter baumannii. For Pseudomonas, we know that it's most often related to Ehrlichia with infections of devices. And the problem with the Pseudomonas is that that given bacterial species is intrinsically less susceptible to many antibiotics. And that's the reason why as soon as there is acquisition of an additional resistant trait, it's extremely difficult to be treated. And Acinetobacter is quite uncommon in bloodstream infection, but when it happens that it is involved in that kind of pathogenicity, the problem is that there is an issue with multi-drug resistance because that given species is very often extremely resistant to antibiotics. If you do consider a kind of scale for different threats according to the WHO, you see here on the left that among the urgent or serious threats, there are the Carbapenem resistance Enterobacterales and the Enterobacterales producing extended spectrum beta-lactamases. Let's have a look on the epidemiology of resistance in different parts of Europe for different pathogens. So the first slide here, which is sourced from the ECDC, is related to E. coli. In 2019, resistance to broad-spectrum cephalosporins within isolates recovered from different infections are represented here. And as you may see, the highest rates are in Italy and in Greece, where you have both 25% of isolates being resistant to broad-spectrum cephalosporins. And still the rate is pretty high, within 10 and 25% in many countries such as Spain, Germany, and the UK. Then if you look at the world map, according to a recent review published in Journal of Travel Medicine, you may see here that the scale is even higher, with a percentage of resistant isolates, invasive isolates, E. coli isolates, being over 75% in some countries, such as Indian subcontinent, such as Russia, some African countries as well. Now, when looking at Klebsiella pneumoniae, still in 2019, still resistant to broad-spectrum cephalosporins and still invasive isolates, you see that the situation is even worse because we have some countries with a percentage of resistances being over 50%. And again, you have Italy, you have Greece, you may have Romania, and so on. And in France and Portugal, you see here very worrying threats because we have a kind of resistance between 25 and 50%. So that mirrors more or less what we do observe with E. coli, but to a higher extent. So that means that when you have such high rate of resistance to broad-spectrum cephalosporins, you need to use Carbapenems as a key option for bloodstream infections. So there are few other options existing when dealing with those resistant gram-negative bloodstream infections. Carbapenems is supposed to be the best, also according to the recent Merino trial, who tried to figure out whether there could be some other options. And for instance, piperacillin tazobactam was used to be considered as an alternative, but the recent findings of this trial do not support the use of pip-tazo in this setting. So let's have a look now on resistance rates to carbapenems, still in these invasive isolates in 2019. And you see here the same countries where you have high rate of resistance for broad-spectrum cephalosporins. You do again see high rates of resistance to carbapenems. And that is very shocking to see that we may have something like more than 50% of isolates in Greece being resistant to carbapenems, Klebsiella pneumoniae. If you compare with Acinetobacter, more or less you have a kind of similar picture with the same countries being flagged as red or even higher, with Italy and Greece with the highest rates once again. So Acinetobacter is supposed to be, as I said, intrinsically resistant, but is supposed to be susceptible to carbapenems. But you may have acquisition of carbapenem resistance in Acinetobacter, like with this given isolate. When you see the antibiogram, you see imipenem and meropenem high level of resistance. The problem is with this kind of isolate, you have also, and you can see here on the right side, high level of resistance to some other antibiotics, non-related antibiotics such as fluoroquinolone, such as aminoglycoside, such as tetracyclines, and so on. So that means when you have that kind of clone circulating, being resistant to carbapenems, that kind of isolate is extremely difficult to eradicate. And which is the main mechanism of resistance to carbapenems in Acinetobacter? It's mainly due to the production of these so-called class D Carbapenemases, or also named oxacillinases. And you have the major determinants being OXA23, 40, and OXA58. And these are the most commonly identified Carbapenemases in Acinetobacter baumannii all over the world. Finally, let's have a look on Pseudomonas aeruginosa, still in 2019. Resistance to carbapenems with a collection of isolates corresponding to invasive infections. So you have here most countries with rates of resistances varying between 10 and 25%. You see here from Portugal, Spain, France, Germany, Italy, Poland. But you also have countries where the percentage of resistance is reaching 50%. So the problem of those carbapenem-resistant isolates, as I said previously, is mainly due to the production of acquired carbapenemases, genes being horizontally transferred from bacterial isolates to bacterial isolates. The problem is there is very often difficulty of detection in the clinic and in the laboratory. And there is also very high difficulty in terms of treatment due to the multi-drug resistance pattern of those isolates and few drugs remaining active. And there is a difficulty thereafter to limit the transmission and the spread of those clonal backgrounds and to control the outbreak either at a local, regional, national, or international level. So for all these different reasons, we need to have diagnostic tools. If you have a look here on the situation in the country where I am, in Switzerland, you see here that it was nicely summarized in a paper published in Neurosurveillance recently, which is the temporal evolution of this carbapenemase producing isolates. And you see that year after year, we have more and more resistance rates to carbapenems due to these carbapenemases, either being from isolates recovered from infections or from colonizations. And if you look at the bacterial genus of those different isolates, you see here that Klebsiella pneumoniae is the pathogen number one, just followed by E. coli and Enterobacter. And if you look at the resistance determinant, the carbapenemase determinants, you see that OXA48, NDM, and KPC are in the top three of the carbapenemases, as in many other countries, and especially many other European countries. If you look at this nice map here in May 2015, the different carbapenemases producers were summarized, and you see here that there are some countries where the situation is considered to be endemic, some others where there is interregional spread, so it's reaching such a rate that it will soon be considered as endemic. And there are some other countries where still, unfortunately, it remains sporadic. For all those countries, you see that carbapenemase producer may be difficult to be recognized if there is no very serious implementation of hygiene and infection control measures. If you look at the different carbapenemase determinants all over the world from invasive isolates, you see here that more or less we may consider to have NDM and KPC being the two champions, with NDM being the most commonly identified. So in that review published in Clinical Infectious Disease quite recently, you have here a worldwide map of the different types of carbapenemases you may find all over the world. And you see here that there are some discrepancies. When KPC, for instance, producer is supposed to be considered endemic in the US, in Colombia, and in some other European countries, by contrast, OXA48 producers may remain quite at low level in those given countries. And by contrast, also, where OXA48 producers are identified at high rates, such as North Africa and Indian subcontinent, we have much less KPC producers. That being said, you see here that if you look at these three main carbapenemase enzymes, you cover more or less all the world. So the result is that we have an increasing trend of carbapenem resistance within Enterobacterales. When you look at E. coli strain being resistant to carbapenem because of the production of the NDM1 enzyme, for instance, this is what we did by performing whole genome sequencing of that given strain recovered in France. What we identify most of the time is the series of lots of resistant genes being located on different plasmids. For instance, for that given isolate, there were at least 4 plasmids on which we may find all these different resistant determinants. And if you add, in addition, some chromosomally encoded resistance mechanism, that leads to that kind of superbug with resistance to almost everything. In Klebsiella pneumoniae, like that given isolate, that was the first being identified by the group of Team Walsh some time ago, you see here that story is almost the same. You have almost resistant to everything, and it's mainly due to the accumulation of many different chromosomally encoded mechanisms in addition to acquisition of different resistance plasmids. Just a final word on NDM. We know that there is a worldwide spread of this NDM carbapenemases in Enterobacterales that is mainly due to a very high source, which is the Indian subcontinent and some other parts of Asia, including China. So we know that the main reservoir is there, and from that reservoir, there have been some different targets in the world. And then from those secondary targets, there is then a spread from countries to countries and from regions to regions. And in Switzerland, we recently identified that kind of multi-drug resistant Klebsiella pneumoniae that was either hospitalized hospital-acquired or community-acquired, and that led to an outbreak in 2017. And if I mention that given isolate, this is because it was producing a Carbapenemase, which is OXA232, which is an OXA48-like enzyme. But in addition, an 16S RNA methylase, named here FNTF, but there is a series of different enzymes corresponding to these methylases. And those methylases, they do confer high level of resistance to aminoglycosides. So altogether, once again, we have multi-drug resistance or sometimes pan-resistant to all different antibiotics. And that's a big concern when you see that kind of clone circulating, not only in hospitals, but also in the community. So to summarize what we do observe nowadays with Carbapenemases, we may think back to the 60s when there was such a wave and tsunami of penicillinases that was a major concern at that time, with 60–70% being resistant to penicillinases over time. And then there have been, during the 90s and the early 2000s, this emergence of extended spectrum beta-lactamases. And nowadays, depending on the country, we may have something in E. coli or Klebsiella pneumoniae between 10, for the best countries, I would say, and 80% of resistance. And nowadays, we know that Carbapenemases are definitely implemented in some given countries with quite high resistance rates. Fortunately, there are still some countries where the rate of Carbapenemase producer is still low. And that means there is still some hope, and we may act very strongly to counteract this kind of trend that we did observe those recent years. And to counteract that, we really need to put all efforts in the prevention and in the detection. There is some hope also in terms of treatment. Recently, there have been some novel drug alternatives with beta-lactam, beta-lactamase inhibitors combo being released for many of them. There is here this possibility to use a novel cephalosporin together with an old inhibitor, ceftolozane-tazobactam, or on the opposite, a novel inhibitor combined with an old beta-lactam, and they are listed here, cefta-avi, for instance, imipenem-rolebactam. So thanks to these combinations, we have possibility, for instance, here, ceftotazo, to treat infections caused by ESBL producers and the Pseudomonas aeruginosa. Thanks to ceftazidime-avibactam, we may also have the possibility to treat with a high likelihood of success ESBL producers and also Carbapenemase producers, including the KPC producers. Since fortunately, avibactam is a very good inhibitor of KPC. We may also treat with imipenem-rolebactam multidrug resistant Acinetobacter, multidrug resistant Pseudomonas aeruginosa. So there are currently lots of surveys in order to evaluate the rates of resistance to those novel drugs, but it's sure that we have here a nice bunch of different combos that may be able to help in clinics. We have also the possibility now of meropenem-vaborbactam. Again, ESBL producer might be susceptible. Carbapenemase producers, including the KPC, may be also susceptible to that combo. So to summarize, there are some strengths and some weaknesses, with the two major ones being used nowadays, such as cefta-avi and ceftotazo. But for ESBL producer, we have very good activity of those drug combinations, and we have also good activities against some Carbapenemase producers for cefta-avi. The weakness is that there is no action against metallo-Carbapenemase producers and also for Carbapenemase producer Acinetobacter. And very recently, unfortunately, there have been a series of reports describing acquired resistance to those novel beta-lactam, beta-lactamase inhibitors combo. And if you see here some examples that have been reported in that review, in the United States, there have been several reports of isolate being resistant to cefta-avi combination. So most of the cases, it was due to mutations in the KPC enzyme. You see here different examples, Finland, Switzerland, Germany, and so on. Most of the time, the patient has been treated with cefta-avi because he was infected by a KPC producing Klebsiella pneumoniae, and thereafter there have been selection of a mutant corresponding to a mutated KPC enzyme within the same isolate. So that means KPC may evolve toward resistance to cephalosporins. Fortunately, in most cases, when there is this kind of mutation leading to resistance to cephalosporins, there is paradoxically a recovered susceptibility to carbapenems. So that means this enzyme is no longer a carbapenemase most of the time. So in terms of conclusions, we are convinced, all of us, that unfortunately, when you look at the world trends, you see that antimicrobial resistance rates are still on the rise, and the bacteremia caused by multi-drug resistance microorganisms is becoming more and more common. So what we need, and it's not something new, is to implement adequate hygiene and infection control measures, but they have to be accompanied by a reduction of the antibiotic selective pressure. And on the top of that, we need to develop still and to implement rapid diagnostic tools. This is absolutely crucial. I thank you very much for your attention. This is a nice view from Switzerland.